Hi, I am Dr. Ted Barnett, Rochester Lifestyle Medicine Institute's president and founder, sometimes known as Dr. Veggie or the high-tech doctor with low-tech solutions. And I'm so excited to introduce our panelists tonight, which I will in just a second. But I just want to tell you that tonight we have a great topic: gastroparesis and depression, challenges to a healthy lifestyle. We'd love it if you'd partner with our Rochester Lifestyle Medicine Institute to help us change the medical paradigm and empower your patients. We have online referral forms on the website. If you just go to rochesterlifestylemedicine.org, you can easily find those. We have several programs which are certified by the American College of Lifestyle Medicine, which I will show you on the next slide. So we have our 15-day whole food plant-based jumpstart, our own homegrown program, which if you sign up as a physician or healthcare provider, you will receive 10 free CMEs for going through the program with participants. And we have had over 2,500 people go through that program so far from about 44 states and 9 countries. We also run the LIFT project, which we did not develop, but we love running it. It's also ACLM certified, and physicians can also get 10 free CMEs for going through that program. We also run a health coaching program as well, which you can learn more about on our website. You will receive one, as I said earlier, you'll receive one CME for this program tonight. We have several other programs that you can also view on our website that are worth up to 24 CMEs. Please respect the privacy of the patient in case you know who it is. Or somehow figure it out. We just please respect that. This is a healthcare meeting, and I don't think I'll say any more about that. Our case presenter tonight, Dr. Trisha Schimek, is board certified in family medicine and lifestyle medicine. She has dedicated her early medical career to working in under-resourced settings and currently works in California, the county health system as a primary care physician and faculty in family medicine residency. Dr. Schimek's passion is helping and motivating her patients to prevent and reverse chronic disease. She completed her undergraduate and Master of Public Health Studies at Tulane and studied medicine at Jefferson Medical College. She completed her family medicine residency at the University of Wisconsin. In addition, she worked with the Indian Health Service and Partners in Health Mexico and continues to mentor health professionals through that program. Outside of medicine, Dr. Schimek's interests include spending time with her husband and 2 young kids, traveling and exploring new places, searching for and creating nutritious recipes, reading, and anything that will take her outdoors, triathlons, hiking, biking, and camping, much like our own Dr. Sundermann. Okay, Dr. Will Bulsiewicz is our guest panelist. He's an award-winning gastroenterologist, internationally recognized gut health expert, and the New York Times bestselling author of Fiber Fueled and the Fiber Fueled Cookbook. He is adjunct assistant professor of medicine at the Emory School of Medicine. He strives to make gut health education accessible to the masses as the U.S. Medical Director of Personalized Nutrition, company Zoe, and Chief Medical Officer of Methodology. He has authored more than 20 articles, published in peer-reviewed journals, and has given more than 40 presentations at national meetings, presented to Congress and the USDA, and has taught over 10,000 students how to heal and optimize their gut health. Our regular panelists, I'll try to skim over them because you've heard about them before. Dr. Robert Breakey is one of our regulars. He's board certified in family medicine and is the medical director for IHA's William J. Folletti Center for Lifestyle Medicine, as well as the chair of IHA's governing board, and that's in Ann Arbor, Michigan. He's also on the board of directors of Rochester Lifestyle Medicine Institute. Dr. Melissa Sundermann, also known as Dr. Outdoors. So I thought of her when I was seeing Dr. Schimek's love of the outdoors as well. Also does triathlons and lots of other crazy athletic things. She currently specializes in lifestyle medicine with lifespan medicine. Before this role, she practiced lifestyle medicine at Canyon Ranch Wellness Resort in Lenox, Massachusetts, and also at IHA Trinity Health in Ann Arbor, Michigan. She is chair of the Global Wellness Institute Lifestyle Medicine Initiative and co-founder of Revive Lifestyle Medicine Wellbeing Coaching, and she also creates educational content for several health and well-being organizations. Dr. Carrie Graff is the medical director of Rochester Lifestyle Medicine Institute and board certified in both family and lifestyle medicine. She's a graduate of the University of Pittsburgh School of Medicine and has practiced in primary care settings for over 26 years in Western New York. She practiced a hybrid of primary care and lifestyle medicine for the past 10 years and now devotes her time to practicing lifestyle medicine at Love Life Telehealth. She obtained her certificate in plant-based nutrition from the T. Colin Campbell Center at E. Cornell in 2014. And in 2017 was one of the first 204 physicians to become board certified in lifestyle medicine. She spent the first half of her career treating patients the way she was trained with pills and procedures, and she's devoting the second half of her career to helping patients reverse chronic disease with lifestyle medicine. You've already heard about me. I'm board certified in diagnostic and interventional radiology. I'm also RLMI's founder, and I'm chair of ACLM's Type 2 Diabetes Remission Task Force. And thank you for attending. We'd love it if you could consider donating to us. We try to make everything as free or as inexpensive as possible. And we will put that link in the chat as well. Here is our presentation, Gastroparesis and Depression, Challenges to Healthy Lifestyle. And I'm going to stop sharing and turn things over to Dr. Schimek. Dr. Schimek, thank you so much. You got the heavy lifting now.
All right. Hi, everyone. Thank you so much for that introduction, and thank you so much to everyone spending your Tuesday evening learning with us. As Dr. Barnett said, we're going to be talking about gastroparesis and depression, challenges to a healthy lifestyle. So my objectives tonight is we are going to consider the impact that conditions like gastroparesis and mental health conditions like depression, anxiety, PTSD, combined with the distrust of the medical system, can have on adopting and maintaining a healthy lifestyle. And then hopefully we'll be formulating a lifestyle plan for a patient with gastroparesis, pancreatic insufficiency, hypercholesterolemia, and a complex psychosocial history. I specifically decided to choose this case because I found it medically interesting. And I think there's a lot we can learn and contribute to the patient's symptomatology and health trajectory by integrating lifestyle medicine approach with our allopathic treatment options. And then I also found this, case particularly challenging as a clinician because the slow nature of change, like wanting my patient to like adopt these changes faster than she's ready for at the time. So I think this is a really good example of the need for persistence and the value of MI when our patient is in that pre-contemplative stage of change, and planting those seeds so that when they are ready to move into like the preparation and action, they have already had all those seeds planted beforehand. So background, I am currently located in California in the East Bay area of San Francisco. I work for Contra Costa County. I work for our safety net hospital system. Our county mission is to care and improve the health of all people in Contra Costa County, with special attention to those who are most vulnerable to health problems. I'm trained as a family physician, as Dr. Barnett said, and I work as a PCP, but I also focus on medical education, women's health, prenatal care, and transgender health. The other thing to know about our system is we have lots of dedicated PCPs, but we have very limited specialty care. I think we have 2 gastroenterologists, and so a lot of our referrals are external referrals. And then we also have a pretty limited axillary staff. I think there's maybe 2 registered dietitians for the entire county of 11 clinics. So our case today, she's GD. I met her a little over a year ago. She attended my transgender clinic to establish care and restart gender-affirming hormones. She was 35 at the time, and she reconnected with the healthcare earlier that year after having unstable housing the prior 2 years. In regards to her gender care, she has been on estradiol and progesterone intermittently for the past 6 years. She had an orchiectomy and a vaginoplasty in the Kaiser system in 2021. One thing that I do remember her saying when I was taking her history was that micronized progesterone just passed through her. Sometimes she would see the tablets in her stool. And the other thing that she brought up to me during the initial consult was that she wanted to follow up a mild leukocytosis that she had seen when she was seeing the GI specialist, and was told that a prior abdominal CT scan showed inflammation around her prior surgical site. In regards to her past medical history, she had a history of an esophageal ulcer that was healed after taking a PPI, diagnosed gastroparesis, pancreatic insufficiency, gender dysphoria. And then in regards to her psychiatric history, had been diagnosed with major depression, general anxiety disorder, ADHD, and PTSD. Her past surgical history, she's had a cholecystectomy, orchiectomy, and a vaginoplasty. Her family history, her mom has fibromyalgia, chronic fatigue, and IBS. Her dad has high cholesterol, and she told me that her paternal grandmother and grandfather had colon cancer. I don't know the details. In regards to her current medications, she's on atomoxetine, 80 milligrams, bupropion XL 450, escitalopram, 20 milligrams daily, propranolol, 10 milligrams that she takes as needed for anxiety, pantoprazole, 20 milligrams daily, and pancreatic enzymes. She takes 2 capsules with each meal and 1 capsule with a snack. Her social history, she's an artist. She does not smoke tobacco. She tells me alcohol once every 3 months, smokes marijuana daily, tells me she does this mainly for anxiety and for sleep. She's currently living with roommates. She has lots of issues with transportation. She has a trans female girlfriend who is her like major support, helps with most of her planning to get to appointments. She receives financial food assistance, has applied and been denied disability in the past, and specifically tells me she distrusts the medical system. In regards to objective data, vital signs when I see her at the beginning, she's 249 pounds. She's 6'1" with a BMI of 33. Her blood pressure is 104/73 and a heart rate of 98. I did have her do a PHQ-9, which was 16. At that time, we were focusing on her gender dysphoria. We restarted her estradiol 2 milligrams twice a day. She was interested in progesterone use, so we did medroxyprogesterone 2.5 milligrams daily. I ordered some initial labs and told her to follow up in 4 weeks. When I got her labs back, what struck me was her total cholesterol was 237, her HDL was 38, and her LDL was 185. CMP was normal except for an elevated CO2 of 31. CBC, she had told me she had a leukocytosis in the past, that her white blood cell count at that time was 10.2, hemoglobin 12.7. I had done a peripheral smear, which showed mild neutrophilia, consider infection or inflammation. Her folate was normal, vitamin B12 was 442, ferritin 50, A1C of 5.3. Her estradiol was low. She had not been on gender-affirming hormones at that time, was 15, and her testosterone was 43. So when I got that lipid panel back, I sent her like my generic message just saying that she had elevated cholesterol, consider, or that I recommended a whole food plant-based diet. And what really struck me was when she replied, she's like, I have gastroparesis. Everything on that list of foods you recommended, I can't tolerate, so hence the cholesterol. So I did see her back 4 weeks later, and at that point, she was feeling much better being back on her gender-affirming hormones, and so actually didn't spend much time on there, and I decided to dig in a little bit more on that GI history. So I looked at her the like specialty notes that she had seen earlier that year, which we'll get to on the next page, but then asked her a little bit about her history. She told me she's had abdominal problems since she was a teenager. These include diffuse intermittent abdominal pain and distension. She has irregular bowel movements, which is generally loose stools and some defecation urgency. She told me if she eats too much or more than a meal a day that she starts to dump. She has feelings of nausea and vomits at least 1 to 2 times a week. When she saw the GI specialist earlier that year for her workup, she was diagnosed with gastroparesis and pancreatic insufficiency. She did do a trial of metoclopramide or Reglan, but stopped this because of some neuropsychiatric symptoms. And she's no longer seeing the GI specialist because she kind of got the impression that there wasn't anything more that he could do for her. I did take a lifestyle medicine audit when I was seeing her at that time. She told me she was eating a pretty high protein, high carb diet with few fruits and veggies. Told me a lot of frozen foods, things like Eggos, or frozen burritos. When I asked further about like any fruits or veggies, she told me she could tolerate blended banana or applesauce. Physical activity, she skateboards and walks. Emotional well-being and stress management is an issue for her. Thankfully, she's connected to psychiatry, and has a therapist that she sees regularly. Has significant financial strain. She's unemployed, is mainly supported by her partner, and has been filing for disability. Social connections have been an issue for her. She lives with her roommates and um, has some issues with some connections with them, and depends a lot on her trans female partner. Sleep, previously had nightmares associated with her PTSD. She said that was much better, but she still has trouble falling asleep, and had interrupted sleep. And substance use, no tobacco, alcohol once every 3 months, and again, that daily marijuana use. Looking at the gastrointestinal workup, so she had gotten labs back in May. Significant for the fecal elastase was low, that was 100. And the GI note noted that the CRP celiac panel, fecal calprotectin were normal and her TSH was normal. She had some studies done. Imaging her CT abdomen pelvis was pretty unremarkable except for some inflammation around her previous vaginoplasty. She had an endoscopy first in March and then again in June. That first time, she had some reflux esophagitis with ulceration, a small hiatal hernia, and mild non-erosive gastritis. She was negative for H. pylori, and they noted that there was copious amounts of residual food in the stomach. Her colonoscopy showed a non-pathological polyp, and after she had taken the PPI for several weeks, well, several months, she went back and showed that she still had esophagitis, now grade A, but that the ulcer had healed, and then she had mild non-erosive gastritis. She did do a gastric emptying scan that was significant for delayed emptying throughout. So we'll, now that we've presented the case, we can take a break for a moment and kind of talk to our panelists about like what sticks out to you about this case and the workup done, and what catches your attention about her lifestyle, and anything that you think might be contributing to her GI symptoms.
Well, thank you, Trisha. That's an amazing case you're presenting. Dr. Bulsiewicz, you're on.
Yeah. Um, this is a highly complicated case. And so I'm grateful for you presenting this to us, Trisha. And I think that, from my perspective, before we even get focused on the digestive symptoms and what's going on there and the questions that exist around those symptoms, I think it first requires us to take a look at the big picture here with this individual person, which is that there are many aspects to this person's life and past history that I think are potentially contributing to what we're seeing and experiencing here. And so there was mention of PTSD, there's clear socioeconomic issues, there's instability of housing, concern for the roommates. I worry about a history of abuse with this individual. I don't know if that conversation has ever been had. I do worry about a history of sexual abuse as well, or something of that variety in the past. And the reason why I bring this up is that, first of all, the patient is skeptical of healthcare. And if we're going to get anywhere, we have to really invest into the doctor-patient relationship. To me, this is the foundation. And some of the questions that I have, I would not be able to ask at the first visit, clearly. It would require multiple visits for us to get there. The second thing is that this is a person who clearly has complex abnormal gut motility. And we call these functional GI disorders. And actually, my mentor at the University of North Carolina, his name is Doug Drossman, and he's the founder of the Rome Foundation. The Rome Foundation is what established the criteria for irritable bowel syndrome and for other functional GI disorders. And he's been studying for 40 years what he would describe as the biopsychosocial model of digestive disease, where things such as our childhood or sexual abuse or trauma can ultimately manifest with a picture such as what we're seeing here. So, and I think that from my perspective, the reason why I bring this all up before I get into the nitty-gritty of the digestive symptoms, I think that it's important for us to see the whole person and to understand that part of healing is more than just whether or not we put them on Reglan for their gastroparesis. So, with regard to the digestive symptoms, and I'll try to be brief here, but it's a little bit tricky and challenging because this is quite complex. I think that we have to separate the gastroparesis from the other symptoms for a moment. The gastroparesis, from my perspective, is clearly present. We have the gastric emptying study that shows this clearly. We have the fact that when they did upper endoscopy, they found remnants of food. And we have the history of acid reflux with esophageal ulceration, which is likely caused by the delayed gastric emptying. This is quite firmly established from my perspective and likely responsible for the nausea and vomiting. But there's this other aspect, which is the abdominal discomfort, the feeling of distension, the sudden urgent bowel movements that sound like diarrhea. And the question from my perspective is, what's causing that? And it's been attributed to exocrine pancreatic insufficiency. And the reason that it was attributed to that is because of the fecal elastase. So for the people who are here tonight and are wondering, what is this? So this is a poop test. And basically what they're doing is they're checking for this, I believe, enzyme. I might be wrong here, enzyme or protein, but nonetheless, that's produced by the pancreas. And that survives passing through our intestine. So basically, when you check it in the poop, it's 1-to-1. If it was produced in the pancreas, it shows up in the poop, and you can make an assessment. If the pancreas is not doing its job appropriately, then it's not producing as much elastase, which is why we get a low number. The number here was 100. Anything less than 200 would be abnormally low. In the range of 100 to 200, it's indeterminate. Less than 100 is a highly compelling argument in favor of exocrine pancreatic insufficiency. But I would actually challenge whether or not this patient in fact has EPI. So if a person has loose watery stool, you cannot send that sample for a fecal elastase because it will give you an abnormal, artificially lowered number and result in a false positive for EPI. Additionally, the person, this patient has no prior history of pancreatic disease, and the imaging is normal. So we have no reason to suspect abnormal pancreatic function. So from my perspective, it makes me skeptical with that. So the way that I would approach this patient is that I would initially start by, I guess, like, again, separating the gastroparesis from this other constellation of symptoms. Number one, we need to know why this other constellation of symptoms. And there's a part of me that the first question that comes to mind is this constipation with overflow diarrhea? Because it would be a quite perfect story for that. The bloating, the distension, the urgent bowel movements, the triggering with a meal. Now, it could just be diarrhea. But nonetheless, what I would do is I would go to the CAT scan and look at the pictures myself. And with full respect to Ted, who I appreciate, and Ted, I think I've said this before in one of our prior sessions, I feel like poop within the colon tends to be overlooked by radiologists unless you directly ask them to make an assessment of that for you. And I've seen many patients where it's described as mild constipation, and in fact it is severe. And in a person who's having chronic diarrhea, if you discover that their colon is completely filled and distended with poop, then this is a highly compelling argument for, in fact, this issue not being diarrhea, but instead being overflow diarrhea due to chronic constipation. So, and that could be the results, again, going back to the big picture view, in taking a sexual history of this patient, I would, be curious. Again, I would never ask this on the first visit, but once trust is established, I'd be curious about history of anal intercourse or any sort of anal trauma, because this can result in pelvic floor dysfunction. So, and create a picture like this. Now, I could go through all the algorithms of the things that I would do if this is not constipation with overflow. Some of them, just for you, Trisha, I would check on the upper endoscopy report, make sure they biopsy the small intestine, because to me, serologies for celiac is not adequate. I want to see the biopsies on that. And then I think that we need to also think about the medications, which most of these psychiatric medications can trigger diarrhea. So just something to be aware of. Real quick on the gastroparesis. Why would this person have gastroparesis? They clearly do not have diabetes. Unfortunately, in our system, it's quite common for people to call this idiopathic. Idiopathic means that you've thrown your hands up and you're not trying to figure it out anymore. There's a number of different factors that can be contributing to this person's gastroparesis. Number one, if they did in fact have severe constipation, that would cause it. Number two, the hormonal therapy could also potentially contribute to this. This is a complex topic because we don't have data on a transgender female of the effects of HRT on gastric emptying. But what we do know is in women who are postmenopausal on hormone replacement therapy, it does affect gastric emptying. And the third thing is the marijuana use, which we can talk about more. But I would be curious to ask the patient if they enjoy taking hot showers and find symptomatic relief when they do that. And I'll explain that more later, but I feel like I've talked enough.
Wow, no, thanks for that. Well, Dr. Sundermann, your thoughts, please.
What he said.
Exactly.
No, thank you so much. And if what sticks out about this case is I'm really happy that this patient has you, Dr. Schimek, as their physician. And I really wish that a gastroenterologist like Dr. Bulsiewicz was in your area, because I feel like so many of these patients that come and find us in lifestyle medicine, they've been given a diagnosis, right? And there's no further look to the underlying root cause. And I feel that that's what you are teasing out is, okay, you're given this diagnosis, but why? And it feels like that's what this patient kind of was like, I'm not going back to GI because they just gave me a diagnosis. I don't have any faith in them. So I'm really happy that this patient has found you, because you are going to look into what is the underlying root cause, and having access to someone like an amazing lifestyle medicine gastroenterologist, Dr. Bulsiewicz, who's like, I'm just not buying just given this diagnosis, and, let's move on. Let's get, to the underpinnings of this. And I really appreciate, Dr. Bulsiewicz, you talking about, let's look at the psychosocial model here. And I'm curious to do, and maybe you don't feel like you've developed enough relationship at this point to do an ACE questionnaire with her, looking for adverse childhood events on her at all. Because I agree that, just wondering if what her background is, and maybe even asking her the question, where did this distrust of the medical system come from? Why has she had, she's obviously been in the medical system with undergoing transgender care and surgery and hormonal, but where that came from in terms of her feelings about that. So I think that when we're looking at, her, we'll learn more about her other pillars of lifestyle medicine. But when we think about, as we approach it as spokes on a wheel with all of those pillars, how they are all interdependent upon each other, and, coming together for the root cause of why she is not feeling well. And I really appreciate having Will's input on this, because it's absolutely fascinating to really dig deeper than the diagnosis that she was given.
Yeah, thank you, Dr. Sundermann. Dr. Breakey, Your thoughts, please.
Yes, thank you, Trisha. This is an excellent case, and my esteemed colleagues have outlined that it's definitely multifactorial. And to me, one of the key reasons, though, and is that in this case, the wrong food for the wrong animal, initiating a known physiologic response to that, and then being labeled as a disease is what we're seeing at our roots. And let me explain what I mean. For millions of years, humans evolved on a whole food, zero processed foods, high fiber, plant predominant diet with probably less than 5% animal and no processed foods. When you put into the stomach foods that are very high, especially in fat and protein, a normal physiologic response is to delay gastric emptying. We know that fat in the duodenum stimulates cholecystokinin and secretin, which have the effect to decrease antral tone and increase pyloric tone. That's why you feel full longer after a fatty meal, and people like that sense. Similarly, with protein, the osmotic load from many peptides from protein digestion has a similar effect to delay to delay gastric emptying. And much like many people have Raynaud's phenomena, a exaggerated response to that, protecting your core temperature. Some people have an exaggerated response to the excessive fat and protein American diet. In general, the blue zones have about 80% from whole on complex carbs, 10% protein, and 10% fat. So we feed our kids from an early age with the wrong food. They develop these symptoms. And then the stomach, as it's churning on these foods for 4, 6, 8 hours sometimes, as Dr. B mentioned, there was still some there in the endoscopy food in there. There's only 2 ways out. One, which has the closed sphincter, and the other means more is going to come upward. So this imbalance then of delayed emptying, GERD, esophagitis, other, is largely, in my mind, blamed on the standard American diet, just like a chronic cough in a smoker is blamed on smoking. The digestive system takes the brunt of this wrong diet and is often the one that gets most of the challenge. That's my 2 cents. I agree definitely, too, that vagal nerves can both stimulate and inhibit gastric emptying and whole colonic alimentary canal stimulation and peristaltic waves. And so stress definitely plays a huge role too. But this person needs to get on a better high fiber diet to help turn this around.
I just want to play off of that because I think it's a great point, which is that if it is true that the person has EPI, exocrine pancreatic insufficiency, and they clearly have gastroparesis, a low-fat diet would be the way. And so I completely agree with you.
Wow, thank you for that. Wow, this is an amazing conversation. Dr. Schimek, back to you, please.
Sure. Excellent. So I thought at this time we would just make sure everyone was on board with gastroparesis and understanding what that is. So we've talked a lot about that the symptoms of gastroparesis are often nausea, upper abdominal pain, vomiting, bloating, fullness, or early satiety. So you have that with an abnormal gastric emptying in the absence of a mechanical obstruction. And the prevalence and the risk factors. So like Dr. Bulsiewicz was saying, when I was looking at one study, they broke it down to 36% of this being idiopathic, 29% of it being diabetic, 13% post-surgical, and then there's various other risk factors or reasons behind gastroparesis. And then there's lots of overlap with functional dyspepsia. And I think one of the clinical questions I had was, does this change over time? Like we have this, one point in time that we had this gastric emptying scan. There was a study that was published in Gastroenterology in 2021 that they looked at patients who were classified with gastroparesis as diagnosed with a gastric emptying scan. And then 48 weeks later, they repeated the gastric emptying scan and found that 42% of them changed into now the diagnosis of functional dyspepsia because they didn't see the gastroparesis anymore. But yet their symptoms that they measured based on the GCSI, the gastrointestinal or gastroparesis cardinal symptom index, didn't change. So in spite of a change on their objective, like gastric emptying scan, their symptoms had remained the same, which I think is interesting. So a question for our audience is, well, now we know that we have this diagnosis, but how are you going to address her elevated cholesterol and gastroparesis with nutrition? Would you like to suggest she start intermittent fasting? Would you like to have her follow a low-fat, low-fiber diet? Would you like to have her start eating mashed or blended fruits and vegetables? Would you like her to add a fruit or vegetable with every meal?
All right. Dr. Bulsiewicz, what is your reaction to this poll?
Let's see here. So first of all, the answer that was selected predominantly by 60% is the one that I would agree with, which is that we do want to get fiber on board, but we have to get fiber that's going to be easily digestible. So in a way, almost pre-digested for this patient. Adding a fruit or vegetable with every meal. So yes, we want to get fiber up. And I think that the challenge to this answer is the skin that exists and also the raw fruits and vegetables, because as much as we may chew them, we're not really fully breaking them down. And the result of this is that it can accumulate in the stomach that's slow to move and create almost like a gastric bezoar. And this is what was seen on the endoscopy. So we just want to be cautious about that.
Okay, Dr. Sundermann, your thoughts, please.
I chose C as well. And as we're going through this case, I don't know if everyone has been to one of Dr. Bulsiewicz's presentations, but he has this amazing slide that it's yellow and it's, symptoms and diseases related to dysbiosis, right? And there's all these different categories. And basically everything, I'm convinced, is related to dysbiosis. And I always hear you saying, Dr. Bulsiewicz, eat the rainbow and trying to get 30 different plant varieties per week. And I think that when we're looking at her overall psychosocial profile, we know that she is struggling with anxiety and depression and PTSD. And obviously there's a lot of work that needs to go into that, but we know with the gut microbiome and 90% of our serotonin being produced there and 50% of our dopamine, I think that we need to optimize her gut microbiome. And what I see is by getting her to tolerate and learn ways that she can tolerate by pre-digesting the fiber, but trying to really create more diversity in that gut microbiome, I think is gonna we're really going to hopefully see some improvements in not only her GI symptoms, but in many of her other symptomology that she has.
Thank you for that. Dr. Breakey.
Yes, I agree. You need to get the high leverage nutrients, phytonutrients, antioxidants from fruits and vegetables and blending or pre-mashing them in this transition phase when she still has the gastroparesis is the way to go.
Thank you. Dr. Schimek, was that what you were expecting?
Yes.
Okay, good. We want to make you happy.
Yes, great job, everyone. Because I was really struck right when she told me, like, which I think is the advice out there, unfortunately, for gastroparesis is like, oh, you should have a low fiber diet. Which makes sense that because it takes time to break down these, but it also goes against to what is like a very healthy diet. And we know that fiber is good for us. So how can we get fiber in a more easily digestible way? So starting with small amounts. So we talked about starting with like a quarter cup or less. And that with fruits, like canned fruits without skins can be easier to digest. Seedless melons, ripe banana, cooked fruits, and vegetables that are well cooked without skins or mashed. And then proteins, thinking about pureeing beans like refried beans or cooked lentils or split peas in a pureed form. And there was a study that I wanted to bring up because I think we give dietary advice, but before we didn't have a lot of randomized control trials looking at the dietary advice that we're giving patients with gastroparesis. This is a particular one from 2014 in the American Journal of Gastroenterology, and it looked at 56 patients, and it looked at small particle diet, which what that means is just, can you mash the food with a fork, versus the general traditional low fat, low fiber recommendation, and looked at how do those two diets affect the patient's symptoms. And they found that actually recommending a small particle diet decreased the patient's symptoms of nausea, vomiting, fullness, bloating, abdominal pain. And then wanted to take a small moment to talk about exocrine pancreatic insufficiency. As we were saying before, that our pancreas is in charge of releasing all of these enzymes to help us break down our food so that our nutrients can be absorbed in the small intestine. And when we have exocrine pancreatic insufficiency, we don't have that proper release of enzymes. And so food goes undigested, and nutrients aren't absorbed, and we can have symptoms of vitamin deficiencies, malnutrition, weight loss, abdominal pain, cramping, steatorrhea. So an audience question for us all is like, what is not a cause of chronic pancreatitis and exocrine pancreatic insufficiency? Would it be autoimmune pancreatitis, alcoholism, cystic fibrosis, diabetes, hypocalcemia, pancreatic cancer, or smoking?
All right, I'm not going to put our panelists on the spot here. So, Trisha, what was the correct answer?
Yeah, actually, it's what people put, E, hypocalcemia. So it's actually the opposite, that hypercalcemia, which can lead to increased stone production and obstruction. But all of these other reasons can cause exocrine pancreatic insufficiency. And then some of the other ones that aren't listed here might be surgery on the digestive tract, a lot of our weight loss surgeries, celiac disease, inflammatory bowel disease. And then there's certain drugs, one of which, when I was like looking this up, can be estradiol. Although, yeah, so it got me thinking for this particular patient, what could be the cause? And then again, we have to go back to decide, does this patient even meet criteria for that diagnosis?
Dr. Bulsiewicz, would you comment on that, please?
I would love to make a quick comment on a couple of quick teaching points from this, if it's okay. So, number one, actually, exocrine pancreatic insufficiency is far more common within the presence of diabetes than most people realize. So, and because diabetes is becoming so increasingly prevalent, we have to be aware and conscious of this possibility in our patients who are suffering with gut symptoms, particularly bloating and diarrhea. And if they happen to see fat in the stool, that's even more convincing. So up to 50% of people with type 2 could potentially have this, and even more prevalent with type 1. And then the other thing I wanted to mention real quick is that in the presence of pancreatic cancer, be aware of the fact that pancreatic cancer can affect pancreatic function, which includes pancreatic endocrine and exocrine function, endocrine meaning blood sugar. So Ted, does that address what you wanted me to? Do you want me to talk about the estradiol?
Yeah, I want you to talk about the estradiol as well, if you could.
I haven't personally seen this. So from my perspective, Trisha, is it possible? I would imagine yes, but again, I think what I come back to is the first question is, does this patient have EPI in the first place? That's where I would start.
Interesting.
Can
Yeah.
I ask Dr. Bulsiewicz, can I ask you a question about supplementing with pancreatic enzymes? At what point in the decision tree do you decide to do that? Obviously, if this is related to type 2 diabetes, we're looking for reversal, right? But at what point while you're trying to work on that, do you start supplementing with the pancreatic enzymes?
Yeah, so where introduce this is that typically this is a person with complex chronic digestive symptoms. Bloating is a part of it. Many times diarrhea or loose stool will be a part of it. They may notice some fat or like an oil slick in the toilet bowl. And I'm going to work through my process. And for someone who has imaging abnormalities that would suggest chronic pancreatitis, it becomes much more straightforward and clear. In the person who has a completely normal pancreas on imaging, if they have diabetes, then I'm more likely to consider this possibility because the diabetes would explain why they would have EPI. And within that context, that's where I would potentially do the fecal elastase, see what it shows, and if it's low, then initiate the enzymes. I would not initiate the enzymes as like a therapeutic trial because it can potentially have placebo effect and just create confusion. And they're very expensive.
Mm-hmm. Thanks for that. Dr. Breakey, you have any comments?
Yes, all of these conditions, with the exception of cystic fibrosis, which of course is genetic, are also related to lifestyle measures: alcohol, smoking, risky substances, pancreatic cancer, autoimmune disease from the American diet, largely diabetes, obviously. So indirectly, that's to blame for many of these common causes. But even backing up from there, again, never in human history, if we think of a normal diet as 10% protein, 10% fat, the American diet is 18 to 20% protein and 33% fat, means that never in human history has the pancreas had to form so much lipase and protease as it does now on the American diet. The poor thing's overwhelmed. Anyway, I'm exaggerating a little bit here, but we have, again, another case of the wrong food for the wrong animal, with pancreatic insufficiency being labeled as a disease. And now we hear ads on the radio for the drug companies that treat this disease, and all of these things we can do when the answer is on your fork and spoon and plate.
That's a great point. Thanks for that, Dr. Breakey. All right, Dr. Schimek, you may proceed, please.
Thank you. Do you guys want to comment any more about any lifestyle interventions that can be used to address? Actually, we'll go back to that because I think we do want to comment about the cannabis use. So this patient uses fairly regularly. When I asked her specifically how much, she says a fair amount. And then I asked her how much is a fair amount, and she says sometimes several times a day. And we kind of have this paradox with gastrointestinal symptoms and cannabis use, that it can be used to improve nausea, abdominal pain, stimulate appetite. But then we can have the opposite effect and complications of slowing gut motility, cannabinoid hyperemesis syndrome, and I think especially in this patient, amotivation.
Yeah. Okay, let's hear about we'll get back to that. Let's keep going, and then we're going to come back to that point as well, I think.
Okay. So I didn't see the patient all fall, and then had a return visit in March, about 6 months after I first met her. I see her back in gender clinic for a medication refill. She's very happy with her hormones, but again, brings up the fact that she's having trouble eating. She does have an assigned PCP that she's only met once the year prior. Reports poor appetite, has been drinking mainly Ensure. She vomits if she coughs or sneezes, has ongoing loose stools in spite of pancreatic enzymes, which also I think begs the question then. Doesn't want to try metoclopramide again, and is not ready to entertain nutrition recommendations until her appetite and vomiting improve. In regards to her vitals at that appointment, her weight's up 14 pounds since August. Normal blood pressure and heart rate. At that point, I really wanted to talk about nutrition, but she wasn't ready for that. She had read about erythromycin, and I was like, okay, well, I think we can try this. I had never prescribed erythromycin for gastroparesis, but we did. And I really asked her, I wanted her to go back to see gastroenterology, which she didn't want to do at that time. She thought we could do this together. And so that was where we were at. I did do a telehealth follow-up with her 4 weeks later. She told me that the erythromycin was working very well for her. She said she could feel her stomach moving again. She was having less burping and nausea and no vomiting. And she commented that her mental health meds she thought her mental health meds were working too, because she was in a much better mood, was more focused. She started applying for jobs. So a panel question is, what would you do next and where would you decide to focus with her?
Wow, Dr. Bulsiewicz.
Yeah, so there's two things that I really want to do with this patient. Aside from working up the bloating and discomfort and watery stool, that to me, again, I'll put that to the side. Let's focus on the gastroparesis. So there's two things that I want to do. Above all else, I want to get this patient off of marijuana. So I am highly concerned that this is the driving factor behind these issues. And I don't believe that I can really initiate appropriate medical therapy until we get her to stop. And it's hard because she, number one, is using it in a form of self-medication. And so it's not just for fun, like she's using it for a specific purpose. And second, I think that there's likely there's clearly evidence of some addictive behavior here, in the sense that she's using this on such a routine basis multiple times a day. And so to convince a person to do that is not easy, and it would clearly take multiple visits and trust in order to even bring up that conversation, because it's going to be a hard one. That being said, I would fully unpack my explanation for that. I, for one, like people who want to do whatever they want to do with marijuana, that's fine. Recreational is, that's up to them. But it's the daily use. It's the chronic use. This is when we get ourselves into trouble, and this is when it crosses the line into creating cannabinoid hyperemesis syndrome. And the only way to really get it better is to get them off of it. The second thing that I would do, and it would help to facilitate this transition of getting them off of the marijuana, is that I would talk to their psychiatrist about Remeron. So there are a couple of things that she's struggling with. One is her appetite. Second is her sleep. That's why she was using the marijuana. And the third is nausea. And it turns out that actually you can get 3 birds with 1 stone with 1 medication. So Remeron, mirtazapine, is phenomenal for nausea. Phenomenal. It also stimulates appetite. And it's taken before bed, and it helps with sleep. And so to me, this would not be something that I would be seeing as treatment for any sort of psychiatric disease. I would just need the psychiatrist to help me to figure out how to introduce it appropriately, given the other medications. But I would be using it for the nausea, and with the intent of helping them to get off the marijuana, so that then I can taper this down later. So that's the way I would approach this.
And it's my understanding that marijuana has become a much stronger drug. Sad.
Ted, it's hard for me to fully comment on this. What I do know is this, that I think the regularity of use has changed. I think that there's been a transition where people have shifted, alcohol clearly has issues. People have shifted to marijuana almost with this sort of cultural expectation that marijuana is safe and has no side effects or potential for adverse reaction. And yet, as the gastroenterologist, this is what I saw all day. And it disproportionately affects young people because, in my experience, it tends to be younger people who initiate this. Usually, I think Melissa brought this up, usually when they're a teenager smoking daily marijuana, and they just never stop. And then they end up in the gastroenterologist clinic with nausea and vomiting.
Dr. Breakey, actually, Dr. Sundermann has unmuted herself. So go ahead, Dr. Sundermann.
No, I was just going to say, from what I've heard, is that the strains it's very different marijuana than it was in the 1970s. One of the things that I thought was peculiar, Dr. Schimek, is that she said that she was, felt like she was vomiting all the time, couldn't keep anything down, didn't want to do any of your dietary recommendations. Yet when she saw you, she had gained 14 pounds. And it makes me wonder if she really was not completely reporting, and maybe the foods that comfort foods to her, again, were those highly processed, foods that she felt that she could more easily digest than the whole food plant-based that we were trying to transition her to. And I do want to mention, because Dr. Bulsiewicz we're talking about the marijuana and trying to get her off of that or weaning down. And there's a wonderful podcast episode that just came out this week on Peter Attia's podcast, that Dr. Anna Lemke, who was a keynote speaker at ACLM last year, who wrote Dopamine Nation, I think. fascinating podcast, and she really does speak to this epidemic of marijuana use. And really, you know, what she's seeing is that people use it for anxiety. However, when they're not using it, they have this dopamine crash, right? So then the anxiety happens, and so they use it again. And so really ties into that, really her anxiety that she's experiencing, that she thinks she's using the marijuana to help with that, could really maybe be caused by her continuous marijuana use, and that, you know, she starts to have that dopamine plummet, so she uses again. So I completely agree with Dr. Bulsiewicz that we need to help support her in trying to, you know, wean off down from the daily marijuana use, because that can be a huge contributor to what's going on. Obviously, some of the other lifestyle medicine pillars, she does have some movement, but skateboarding, really not a modern intensity aerobic activity. She's doing some walking. I think that's great. I'm going to, you know, advocate for getting out in nature. You know, that it increases our serotonin levels by being outdoors. And according to Dr. Bulsiewicz, that can help with gastric motility of just and constipation if she's boosting her serotonin. So just a plug for nature as well.
A quick, I just want to follow up real quick, and then I'll let you go, Dr. Breakey. But the same issue that you're describing with the anxiety is what happens with the nausea, which is that they feel better when they're smoking marijuana. And then when they stop smoking marijuana, the symptoms come back. So it's conceptually similar to getting an alcoholic, right? There's like a bodily dependence to getting an alcoholic to quit drinking alcohol when they actually see this as the solution to their problems. So, and the other thing that I would mention, I'm glad that you brought up getting outside, because the serotonin, 95% of serotonin is produced in the gut. And the reason why all of the serotonin is produced in our gut is because it's a motility hormone. So getting outside and reorienting our circadian rhythm with the daily walk in the morning could be a strong and powerful way to improve mood, to improve sleep, and to improve gut motility.
Fantastic. Yeah, Dr. Breakey, quickly, any thoughts?
You know, related to the marijuana, I agree with Dr. B that it has to go. And yet we have to understand that, like with many drug relationships, at least short term or in her perception, it's giving her some benefits. So it has to be done carefully with understanding and caring, and in a manner that will help her to replace whatever real or perceived benefits she's getting from it with benefits from other sources. Preferably from good lifestyle metrics, as we're talking about. One of the observations, when mentioned it over here in the chat, is that in this case with gastroparesis, and I'd be interested in Dr. V's comment, there does seem to be some difference between soluble and insoluble fiber. Insoluble fiber mostly present in raw fruits and vegetables versus soluble fiber, oats, most beans, bananas, avocados, certain other foods seems to be better tolerated. And I don't know, Dr. B, being the fiber guru, I don't mean to steal your when you're the thunder here, but any comments on whether there is a difference in this case? The real answer is eat both, of course, for most people. But in this case, is there a difference between those?
Yeah, I think the real answer. Yeah, I think the real answer, in the interest of simplicity for our patients, is to not necessarily worry about the functional differences between the two, but to really just cook down the food, pre-digest the food. So making it as soft as possible, or using a blender to break it up and disrupt it. But to answer your question, the soluble fiber tends to be the prebiotic fiber. So that's the fiber that's going to be digested by our gut microbial enzymes to produce short-chain fatty acids. Whereas the insoluble fiber tends to be the roughage or grit, which of course is also the stuff that could accumulate in a stomach and not really move.
Thank you.
Yeah, back to you, Dr. Schimek.
Sure. So, unfortunately, we did not even address her marijuana use at that particular, I think I probably forgot since I hadn't seen her for so long, but I was really hoping to introduce some nutritional things with her. Was just like, can we buy a blender to make a smoothie, adding some fiber? We talked about trying adding some garbanzo beans that are blended down or mashed. And we talked about trying a blended soup. I'm going to skip through a little bit. But I had her, she did redo her lipids a couple months or over the summer. Unfortunately, her total cholesterol went up to 271, HDL was 42, and at that point her LDL was 223. And at that point, we did start atorvastatin, in addition to continuing to talk about lifestyle changes. And all of this is done actually through messaging. She had missed a couple of appointments that we had tried to schedule. And then I decided to call her last month in preparation for this case. And just again suggest some of the things with nutrition, but I did bring up the marijuana during our conversation at that time, and I decided to take the approach of just maybe bringing about awareness, and if we could at least get to an agreement that it's possible that the marijuana use could be contributing to some of her symptoms. And during that conversation, we at least got to awareness. She was like, I can agree that it's possible that this could be contributing. I explored whether or not there was any times in the past that she had decreased her use and if there was any change on her symptoms. She was able to note a time that she had stopped and there was awareness that her symptoms were a little bit better. But at the end of that conversation, she wasn't ready to decrease her use, citing that she's using it because it reduces her emotional reactivity, and makes it so she can go about her day. And I know we're over time, so I'm going to leave it at
That's
that.
okay. Is that your last slide?
Yeah, well, some pearls from the case.
Sure.
So adoption of an unhealthy dietary and lifestyle habits for gastrointestinal symptoms can negatively impact our mental and physical health, as Dr. Sundermann was saying, right? A lot of our serotonin is produced in our gut, and that there's tremendous value in healing our gut and microbiome. For patients with gastroparesis, thinking about recommending a small particle diet, can you easily mash it with a fork? Those well-cooked fruits and veggies without peels, mashed and emulsified whole foods. Getting buy-in from the patient and coming up with achievable nutrition prescriptions with regular scheduled check-ins to see how those are going and what changes need to be made. Cannabis may be used for nausea, appetite stimulation, and chronic pain, but it can also cause slow gut motility, cannabinoid hyperemesis syndrome, and amotivation. There's a lot of value in planting seeds for lifestyle changes during the contemplation stage. And I'm also curious if the panel wants to share any of their takeaways from this case.
Yeah, that's great. Thank you. I'm going to make a couple of announcements first. If you could just stop sharing, and Dr. Graf, your medical director, has been in the background. We're going to call her up. I want to remind people that we are a nonprofit, and if you're interested in donating to our cause, we are trying to change the healthcare system. That's a QR code you can name your phone at, and Bob will put a link in the chat as well. Dr. Graf, would you like to lead a conversation here?
A question for Dr. B about how long it takes for that hyperemesis effect to go away when people stop the marijuana. Like if you stopped it cold turkey, what would you expect to kind of be the earliest you'd see it, and what's the longest it should take to go away?
That's a great question. I have not seen clear data on exactly how long, but the reason why I like the Remeron is because it can be just sort of this temporary thing that you're using to help to make that transition, and then you can taper it off when you're done. So if I were to venture a guess, I would probably say something on the order of 2 to 8 weeks, something like this.
So definitely you wouldn't expect to see it within a week. So if the person stops it for a week, doesn't see an improvement, it goes back to using it, you're like, you gotta give them like.
I don't want them on it. So from my perspective, there's just no way for me to know that I'm properly taking care of the patient if they're continuing to smoke marijuana.
Interesting.
What would you do with a patient like this if she was continuing to smoke the marijuana? Would you just kind of say, look, I really can't help you if you don't do this?
I would do everything. I would have a I think the part of this is, again, like acknowledging the challenges that exist with this particular patient, like, and having compassion for the patient, recognizing that if I dismiss her, she's going to get probably the same or worse from the next doctor. So trying my best to try to like I think that the way that Trisha approached this was completely appropriate, that you're just trying to build on your relationship. That being said, I do think that there needs to be certain lines that do exist in terms of our care. Me personally, I wouldn't treat around the marijuana if I thought the marijuana was the issue.
I actually have a question. I'm still stinging from the comment about radiologists missing the constipation. So I'm
Oh,
wondering.
Ted, it's
No,
with
it's okay.
love.
No, I know, I get it. I'm just actually curious. How do we know she doesn't have constipation as the cause of the gastroparesis and her overflow diarrhea and all at this point? Have we?
She absolutely could.
Yeah.
She absolutely
Trisha,
could,
have
because
we-
constipation, severe constipation could present exactly like this.
So Trisha, have we evaluated that?
I can go, well, actually, she did the CT in an outside system, so I'd have to get the actual images. I just have the report.
Okay.
But that's one thing. And I mean, she always comments about the loose stools and the fecal urgency. Like when I asked about like hard stools or hard to push out, she said no. So I think, yeah, looking at the imaging and
I'd be happy to look at that with you if you want.
Yeah, and
Especially that urgency is, that overflow, that stool overflow thing is,
That's right.
is like classic for that.
Yeah, that's right. It's the liquid. It's the liquid stool that would give you urgency no matter what. And so two quick comments. The one is the possibility, as you're saying, Carrie, of overflow. And you should see that on the imaging and be aware of the possibility of a pelvic floor issue, because people that have pelvic dyssynergia, they're unable to relax their pelvic floor muscles. And again, pelvic dyssynergia seems to be disproportionately prevalent among people who have a history of sexual abuse of anything of this variety. So it's just bringing consciousness to that possibility. The second thing that I want to mention real quick is there's also a pattern that can exist that we need to be conscious of as healthcare providers, where a person can come into your office and say, I'm having chronic diarrhea. And they go, I don't poop for 3 days, and then I poop all day. And the pattern always goes like this. The first poop on that day when they go is a solid formed stool. And then it gets looser and looser and looser, and they do have urgency. And they have cramping, and the cramping's improved after they poop. This is constipation. They back up until they explode. And so they'll back up for 3 days, and then they'll have a poop day, and they'll have diarrhea. And if you actually treat them for constipation, they get better. But the problem is many people put them on Imodium. We make it worse. Same would be true for overflow.
Yeah.
Ted, I just want to comment on the fact about radiologists not calling it for constipation on their CTs. I just had that yesterday for a case, and it was super frustrating. Like, she was in the emergency room 3 times, and like neither her MRI nor her CT scan remarked on the fact that she was really full of poop, and that was the main problem. But they were focused on her liver and her pancreas and all kinds of other things, and I'm just like,
Carrie,
anyway.
The key with this is, I think the teaching point is to directly ask your radiologist, is there constipation? Because then they will answer this. All the other stuff about the internal organs like the liver and the pancreas, they're going to comment on anyway, right? So, and I think that the other thing is, I think it's good practice to take a look at our CT images ourselves when we can.
Yeah. Well, this was a patient who had done a 3-day bowel clean out and had a moderate amount of stool, but had completed like was on clear liquids and had done a bowel clean out for 3 days. I'm like, yeah, it's still constipation. You're still full of stuff. So
Moderate is also always severe.
well, there's that. But anyway, to be kind, the radiologist didn't know that the person had just done a 3-day bowel clean out. So,
well, on behalf of my entire specialty, I apologize.
still love you, Ted.
I have a comment. So
Sure.
I saw Dr. Schimek at the end of that last slide, or the second to last slide, something about ketamine. And to Dr. Bulsiewicz's point of like, we've got to find a way for her to stop using marijuana. Now, in order for her to give up that, something that she is so tightly, feels dependent upon to get through her day and her anxiety, I'm wondering if she brought that up or if you brought that up. And there was just a study that came out, because I'm just trying to wrap my head around this emerging field of ketamine and psilocybin and microdosing that just came out a couple of days ago. It was the first trial looking at psilocybin versus SSRI for treatment of depression. And actually psilocybin outperformed the SSRI for treatment of depression. And I'm wondering if she brought that up of something that she might be interested in, if there's any psychiatrists or integrated psychologist that, because I feel like in order to tell her she has to quit this, there needs to be, well, what am I going to do about my anxiety? And we know that, all these other pillars of lifestyle medicine, once we can get those better, probably her anxiety is going to be better. But with that history of that PTSD and perhaps a history of trauma, I'm wondering if she or you want to explore that in your area. I don't know. I mean, I think that we're starting to see this form of medicine being utilized for refractory depression, anxiety, and PTSD.
Yeah, she is exploring it with her psychiatrist right now. So was looking into getting ready for that. It also got a little bit deeper when I was talking to her last time, that she was looking at other diagnoses with her psychiatrist about dissociative identity disorder. So that was like another thing that came up. But yes, she was looking at ketamine, and I was actually kind of encouraging, like, she's trying other things up to this point and still having a really hard time.
Go ahead, Dr. Breakey.
Dr. B, I wonder if you could comment. Commonly, when people feel like they're not getting enough nutrition for whatever reason, nausea or other, they turn to Ensure. And I did put the ingredients in the chat there, everything from cow's protein to corn syrup to cellulose gum to sucralose. What effect does this without being a leading question, this pure, unadulterated, ultra-processed junk food masquerading as nutritious, what effect does that have on a person's GI system and their microbiome?
That's a good question. I mean, I would be speculating, but I do know there was a study that was a soybean oil-based progression where they basically ratcheted up the number of calories that a person was consuming from soybean oil, and it showed progressive injury and dysbiosis to the gut microbiome. I think that the key from my perspective is that, and this comes back to, some of the approach that we see in the conventional healthcare system of, reducing this down to low fat, low fiber, right? Or in the case of Ensure, it's like, well, let me just get you some calories, right?
Nutrition.
And I think that, it's like it's a reductionist approach where we get fixated on some sort of short-term thing that we think we need, when in fact we need to see this whole picture of, like, in order to properly heal this patient who has complex motility disorder, we need to get the gut microbiome working for us, not against us.
Yeah. All right. Well, listen, this has been a great conversation. Any final comments from our panelists?
I think this wins the most interesting case of the year award.
Absolutely. This was fantastic.
This is a great
It
case.
was great.
Thank you for bringing
Complex
it.
case, and I think you're doing
Excellent.
an amazing job
Yeah.
with this patient.
Really, I
Thank
agree.
you.
And I'm so grateful for our brilliant panelists. And you guys did a great job. And Trisha, thank you for the heavy lifting on this. That's not an easy case to present. So anyway, all right. Well, everybody, thank you all for coming. Be on the lookout for your email to receive your free CME, and take a look at our calendar, and we'll see you in a month. Awesome. All right.
Bye.
Good night, everybody.
Good
Thank
night,
you, Bob.
everyone. Thank you.
Yeah.